Welcome to our comprehensive guide on insulin pharmacology. Insulin is a vital hormone that plays a central role in regulating blood glucose levels. Whether you're a medical student, healthcare professional, or just curious about how insulin works, this video will break down everything you need to know. We'll start by exploring the basics of insulin, its discovery, and its importance in diabetes management. By the end, you'll have a clear understanding of insulin's structure, mechanism, types, and clinical applications. Let's begin our journey into the fascinating world of insulin. Diabetes mellitus is a group of metabolic disorders characterized by high blood sugar levels. There are several types: type I diabetes where the body fails to produce insulin, type II diabetes marked by insulin resistance, maturity onset diabetes of the young, a rare genetic form, latent autoimmune diabetes in adults which shares features of both type I and II, and gestational diabetes which occurs during pregnancy. Understanding these types is crucial as insulin therapy plays a different role in each. Let's look at how insulin fits into the management of these conditions. Within the pancreas, specialized clusters called the islets of Langerhans house several types of cells. Beta cells secrete insulin, alpha cells release glucagon, delta cells produce somatostatin, and F cells secrete pancreatic polypeptide. Each cell type has a unique function in regulating metabolism and maintaining glucose balance. The close proximity of these cells allows for precise hormonal regulation. Understanding the roles of these cells helps us appreciate how insulin is produced and released in response to blood sugar changes. Insulin is synthesized in the pancreatic beta cells. It starts as a larger precursor molecule which is processed and stored in vesicles within the Golgi apparatus. In these vesicles, insulin is stored as hexamers, stabilized by zinc ions. This storage form allows for rapid release when blood glucose rises. Upon secretion, the hexamers dissociate into dimers and monomers, which are the biologically active forms of insulin. This process ensures that insulin is available in the right form and quantity when needed. Insulin molecule consists of two polypeptide chains, the A chain with 21 amino acids and the B chain with 30 amino acids. These chains are connected by two interchain disulfide bridges providing structural stability. Additionally, there is one interchain disulfide bridge within the A chain. This unique structure is essential for insulin's biological activity. Any alteration in these bonds can affect insulin's function, which is why structural integrity is so important in both natural and synthetic insulin preparations. In the pancreatic beta cells, insulin is stored as hexamers, complexes of 6 insulin molecules stabilized by zinc ions. This hexameric form is crucial for storage and stability within the cell. When insulin is released into the bloodstream, these hexamers quickly dissociate into monomers, which are the active form that can bind to insulin receptors. The ability to form hexamers, dimers, and monomers is influenced by structural modifications, which can affect insulin's solubility, absorption rate, and duration of action. Insulin is classified as a protein hormone with a molecular weight of about 5.7 kDa. Its peptide nature means it cannot be taken orally, as it would be digested in the gastrointestinal tract. Instead, insulin must be administered via injection or in some cases inhalation. The protein structure also allows for modifications that can alter its pharmacokinetics, giving rise to various insulin analogs with different onset and duration profile. Insulin exerts its effects by binding to the insulin receptor, a transmembrane tyrosine kinase receptor found on the surface of target cells such as liver, muscle, and fat cells. The receptor consists of alpha and beta subunits. The alpha subunits are extracellular and bind insulin, while the beta subunits span the membrane and initiate intracellular signaling. This binding triggers a cascade of events that ultimately lead to glucose uptake and metabolism. Insulin binds to its receptor. The receptor undergoes autophosphorylation on tyrosine residues. This process activates insulin receptor substrates, IRS, which are key proteins that transmit the signal inside the cell. The activation of IRS proteins sets off multiple downstream signaling pathways, each responsible for different aspects of insulin's metabolic effects. This precise signaling ensures that cells respond appropriately to changes in blood glucose. One of the most important pathways activated by insulin is the Pi3-KAC pathway. This pathway is critical for the translocation of GLUT4 transporters to the plasma membrane in muscle and adipose tissues, allowing glucose to enter the cells. It also promotes glycogen synthesis by activating glycogen synthase and inhibits gluconeogenesis in the liver. These actions collectively lower blood glucose and store energy for future use. MAPK pathway is another signaling route activated by insulin. While the Pi3-KAC pathway focuses on metabolic effects, the MAPK pathway is more involved in cell growth and gene expression. This dual signaling capability allows insulin to influence both immediate metabolic processes and longer-term cellular functions, highlighting its importance beyond just glucose regulation. In the liver, insulin increases glycogen synthesis, which is the storage form of glucose. It also suppresses gluconeogenesis and ketogenesis, processes that generate glucose and ketone bodies, respectively. By doing so, insulin helps maintain normal blood glucose levels and prevents the buildup of harmful ketones, especially important in diabetes management. Skeletal muscle, insulin promotes glucose uptake by facilitating the movement of GLUT4 transporters to the cell surface. It also stimulates protein synthesis, supporting muscle growth and repair. These effects are particularly important for individuals with diabetes, as impaired insulin action can lead to muscle weakness and poor glucose control. In adipose tissue, insulin stimulates the synthesis of fats lipogenesis and inhibits the breakdown of fats lipolysis. This helps store excess energy as fat and prevents the release of free fatty acids into the bloodstream. Proper insulin action in adipose tissue is essential for maintaining energy balance and preventing metabolic complications. Modern insulin analogs are engineered to better mimic the body's natural insulin secretion. These analogs have structural modifications that alter their absorption, onset, and duration of action. Rapid-acting analogs absorb quickly for mealtime control, while long-acting analogs provide steady basal insulin. This allows for more flexible and effective diabetes management, reducing the risk of both high and low blood sugar episodes. Insulin preparations are classified based on their onset, peak, and duration of action. The main types include rapid-acting, short-acting, intermediate-acting, long-acting, ultra-long-acting, premixed, and inhaled insulins. Each type is designed for specific clinical situations, such as mealtime glucose control or providing a steady background level of insulin. Choosing the right type is essential for effective diabetes management. Rapid-acting insulins such as Lispro, Aspart, and Glulisine are designed to act quickly after injection. They typically begin working within 10 to 30 minutes, peak in about 1 to 3 hours, and last up to 5 hours. These insulins are ideal for controlling blood sugar spikes that occur after meals, providing flexibility and precision in diabetes management. Short-acting insulins, like regular insulin, have a slightly slower onset and longer duration compared to rapid-acting types. They start working within 30 to 60 minutes, peak at 2 to 4 hours, and last up to 8 hours. These are often used for pre-meal dosing and can be administered intravenously in emergencies such as diabetic ketoacidosis. Intermediate-acting insulins such as NPH neutral protamine Hagedorn provide basal insulin coverage. They have an onset of 1 to 2 hours, peak between 2 to 8 hours, and last up to 24 hours. These insulins are often used in combination with rapid or short-acting insulins to provide both basal and prandial glucose control. Long-acting insulins such as Glargine and Detemir are designed to provide a steady level of insulin throughout the day. They have minimal or no pronounced peak and can last up to 24 hours or more. These insulins are typically administered once daily and are essential for maintaining basal insulin levels, especially in patients with type 1 diabetes. Ultra-long-acting insulins like Glargine U300 and Degludec offer even longer duration of action, sometimes exceeding 30 to 42 hours. These insulins provide a very stable basal insulin level with a lower risk of hypoglycemia. Their flexibility in dosing makes them particularly useful for patients who require consistent, long-term glucose control. Mixed insulins combine rapid or short-acting insulin with intermediate-acting insulin in fixed ratios. Examples include NPH plus regular Aspart or Lispro. These formulations provide both immediate and basal glucose control, making them convenient for patients with fixed meal schedules. Premixed insulins simplify dosing but may lack flexibility for those with variable eating patterns. Inhaled human insulin such as Afrezza offers a needle-free alternative for rapid-acting insulin delivery. It has a very fast onset, peaking within 30 to 54 minutes and lasting 1.5 to 3 hours. Inhaled insulin is particularly useful for patients who are averse to injections, though it may not be suitable for everyone due to lung-related contraindications. Pharmacokinetics of insulin. How it is absorbed, distributed, metabolized, and excreted varies depending on its formulation. Rapid-acting analogs are absorbed quickly and act fast, making them ideal for postprandial glucose control. Long-acting analogs are absorbed slowly, providing a steady release for basal control. Understanding these differences helps tailor insulin therapy to individual patient needs. Each insulin type has unique clinical notes. For example, rapid-acting insulins are best for mealtime glucose spikes, while long-acting insulins are used for basal control. Some insulins, like regular, can be given intravenously in emergencies. Premixed insulins are convenient for fixed meal schedules, and inhaled insulin offers an alternative for those who dislike injections. These distinctions guide clinicians in selecting the most appropriate insulin regimen. While insulin is life-saving, it can also cause adverse effects. The most common and serious is hypoglycemia, which can result from overdose, missed meals, or increased physical activity. Other side effects include weight gain, insulin resistance, lipodystrophy, injection site reactions, hypokalemia, mitogenic concerns, and rare antibody formation. Awareness of these risks is essential for safe and effective insulin therapy. Hypoglycemia is the most frequent and dangerous side effect of insulin therapy. It occurs when blood glucose drops too low, often due to excessive insulin, missed meals, or unplanned exercise. Symptoms range from sweating and confusion to seizures and coma. Severe hypoglycemia can be life-threatening, so prompt recognition and treatment are critical. Weight gain is a common side effect of long-term insulin use, especially in patients with type 1 diabetes. This occurs due to insulin's anabolic effects and the tendency for hypoglycemia-driven overeating. Managing weight is an important consideration when initiating or adjusting insulin therapy, as excess weight can worsen insulin resistance. Chronic high-dose insulin therapy can lead to insulin resistance, where the body's cells become less responsive to insulin's effects. This is particularly common in patients with type 1 diabetes and obesity. Overcoming insulin resistance often requires lifestyle changes, such as diet and exercise, in addition to medication adjustments. Lipodystrophy refers to abnormal changes in fat tissue at insulin injection sites. It includes lipotrophy, or fat loss, and lipohypertrophy, or fat buildup. These changes are caused by repeated injections at the same site and can affect insulin absorption. Rotating injection sites helps prevent lipodystrophy and ensures consistent insulin action. Some patients may experience pain, redness, swelling, or itching at the injection site. Rarely, allergic reactions can occur, but these are uncommon with modern purified insulin analogs. Proper injection technique and site rotation can minimize these reactions and improve patient comfort. Insulin promotes the movement of potassium into cells, which can lead to low serum potassium levels or hypokalemia. This is especially a concern with high doses or intravenous insulin. Monitoring potassium levels is important in patients receiving intensive insulin therapy to prevent complications like muscle weakness or cardiac arrhythmias. Some early studies suggested that certain insulin analogs, especially glargine, might have mitogenic effects by binding to the IGF-1 receptor. However, large clinical studies have not confirmed an increased cancer risk. While this remains an area of ongoing research, current evidence supports the safety of modern insulin analogs. Older animal-derived insulins sometimes caused immune reactions, leading to antibody formation and resistance. Today, human and analog insulins have minimal immunogenicity, but rare cases of antibody-related resistance can still occur. Monitoring for this is important in patients who experience unexplained changes in insulin requirements. In type I diabetes, the body's immune system destroys beta cells, leading to absolute insulin deficiency. Insulin therapy is essential for survival, as these patients cannot produce their own insulin. The goal is to mimic physiological insulin secretion as closely as possible, using a combination of basal and bolus insulin regimens. Type II diabetes is characterized by insulin resistance and relative insulin deficiency. While lifestyle changes and oral medications are first-line treatments, many patients eventually require insulin therapy. The approach is individualized, often starting with basal insulin and adding prandial doses as needed to achieve glycemic targets. Other forms of diabetes, such as maturity-onset diabetes of the young (MODY), latent autoimmune diabetes in adults (LADA), and gestational diabetes, may also require insulin therapy. The choice and timing of insulin depend on the specific type and patient needs. Close monitoring and individualized plans are key to optimal outcomes. Proper storage and handling of insulin are crucial for maintaining its effectiveness. Insulin should be kept refrigerated until opened, then stored at room temperature for up to a month. Avoid exposing insulin to extreme temperatures, as this can degrade the hormone and reduce its potency. Correct injection technique ensures that insulin is delivered into the subcutaneous tissue for optimal absorption. Use a new needle each time, rotate injection sites, and avoid injecting into scarred or lumpy areas. Proper technique reduces the risk of lipodystrophy and improves glycemic control. Regular monitoring of blood glucose is essential for patients on insulin therapy. Self-monitoring allows for timely adjustments in insulin doses and helps prevent both hyperglycemia and hypoglycemia. Continuous glucose monitoring systems are increasingly used for more detailed glucose tracking and improved outcomes. Educating patients about insulin therapy is vital for success. Patients should understand how to recognize and treat hypoglycemia, adjust doses for meals and activity, and properly store and handle insulin. Empowering patients with knowledge leads to better adherence and improved health outcomes. Research continues to advance insulin therapy, with new analogs and delivery systems in development. Innovations like closed-loop insulin pumps and smart insulins promise to make diabetes management even more precise and convenient. Staying informed about these advancements ensures that patients receive the best possible care. Summarize: insulin is a peptide hormone essential for glucose regulation. It is produced by pancreatic beta cells and acts through complex signaling pathways to control metabolism. Various insulin types and analogs allow for tailored therapy in different forms of diabetes. Understanding insulin's structure, mechanism, and clinical use is crucial for effective diabetes management. Clinical pearls for insulin therapy include rotating injection sites, monitoring for hypoglycemia, and individualizing treatment plans. Patient education and regular follow-up are key to preventing complications and achieving optimal glycemic control. Always stay updated with the latest guidelines and research to provide the best care. Thank you for joining us on this deep dive into insulin pharmacology. From its synthesis and structure to its clinical applications and adverse effects, insulin remains a cornerstone of diabetes management. Continued research and innovation promise even better therapies in the future. Stay informed, stay empowered, and remember that effective insulin therapy can transform lives.